Digital technology impacts healthcare in all of its dimensions: research and development, clinical practice, policy, innovation, entrepreneurship, insurance and financing. It leaves nothing as it is. It is not a mere enabler, it is a constitutive technology. It radically changes the very practices and sectors and institutions to which it is applied. We don't need to spend much time on explaining how exactly digital technology manages to disrupt. The picture is clear by now. Incumbents in finance and banking, transport, hospitality, industrial production and retail have all experienced it. You go digital or you disappear. It's also obvious that data and AI can reduce cost in healthcare, improve patient safety, empower patients, and improve the quality of diagnosis, therapy, patient journeys, billing, and logistics. Smartphones and watches with health apps, wearables, and so-called digiceuticals are part of an Internet of Things revolution that is well underway in healthcare. Wearable devices can be used to detect arrhythmia, predict Parkinson via the accelerometer in the phone, measure a range of biomarkers such as blood sugar, blood pressure, fat percentage, oxygen, and stress. They can diagnose skin cancer, retina damage, and assist in management of eating disorders, phobias, depression, chronic pain, and PTSD. They can even gauge the risk of suicide on the basis of social media posts, looking at the time of day of the post, the number of human faces it contains, and the colors. Big tech companies are moving now into healthcare and biomedicine big time. There is a lot of money to be made and big data to be harvested. Big data, in turn, will drive the development of more powerful machine learning and AI, which then leads to superior positions in the market. IBM applies its Watson technology in oncology and uses health data collected via Apple Research Kit and Health Kit. Alphabet focuses via its London-based DeepMind Health on AI for health. They have managed to close deals with the NHS and individual hospitals to get access to large amounts of patient data in the UK, and they're trying to achieve breakthroughs comparable to beating human world champions at chess and Go. Alphabet already claims to be able to predict the death of patients in hospital much earlier than clinicians using traditional methods. Alphabet's City Block Health focuses on low-income inhabitants of cities, mining data to see where care for these vulnerable groups is needed and dispatch healthcare workers to people's home, circumventing existing healthcare infrastructures. Alphabet's Verily has embarked upon a baseline study for good health by following 10,000 patients for 4 years closely, also looking at insurance schemes and population health management. Microsoft just started a new healthcare division in Cambridge looking at medical algorithms. Apple has chosen the hardware route and focuses on smartphones and wearable sensors as medical devices in collaboration with Stanford. Amazon is now teamed up with Warren Buffett's investment company Berkshire Hathaway and JP Morgan Chase to move into healthcare. Uber has laid out plans to use its ride-hailing platforms for transportation of patients to and from hospitals. Admittedly, the first forays into healthcare in the past have not all been good. Google Health failed in 2011, and Google Flu Trends claimed it could outperform the CDC in predicting the flu, but completely missed the peak of the influenza epidemic of 2013. Spurious correlations and overfitting were the culprits. The Ebola crisis in Africa response on the basis of Orange telco calling data was less than adequate for similar reasons. There are serious limitations to a purely data-driven approach and the glorification of statistical correlations. On the basis of a recent critique on machine learning by the leading AI researcher Judea Pearl from Berkeley, one could say that especially in medicine and in other fields of great social importance, the data-driven approach, in order to be clinically useful and morally responsible, needs to be complemented by theory-driven approaches, which aim at uncovering the causal mechanisms. Another set of problems are attitude problems, so to speak. The digital industry and the Silicon Valley approach to healthcare is what Evgeny Morozov has called a solutionist approach, which focuses exclusively on the problems for which we have nice and clean technological solutions at our disposal. David Laser has diagnosed their preferred approach as big data hubris. The idea that there are simple digital solutions to complex problems in a very complex world of healthcare, with its very complex institutional settings, multiple stakeholders, plurality of moral values, and cultural diversity. This is irredeemably and culpably naive. There are not only epistemic failings in the digital usurpation of the health domain, there are also moral concerns. We know that there are racial and gender and many other biases in healthcare data, and they may get entrenched in the algorithms or may be built into medical systems to deceive, to save cost, or to make profits. We have seen with Volkswagen and Uber how this can work. How would we know? Algorithms and black box intelligence in clinical decision support systems affects the fiduciary relationships of doctors and patients. Furthermore, there have been massive breaches of security and privacy in healthcare in the last decade. Google DeepMind Health has been reprimanded by the Information Commission in the UK for their processing of NHS patient data. Google DeepMind replied that they had, quote, underestimated the complexity of the NHS and of the rules around patient data, as well as the potential fears about well-known tech companies working in health, unquote. There are also worrying developments beyond privacy and security breaches and that touch upon human dignity. A US-based company called Aspire Health tries to save on cost in palliative care by estimating which patients will die soon. A discussion in the New England Journal of Medicine of March 2018 states that, quote, there may be a temptation to teach machine learning systems to guide users towards clinical actions that would improve quality metrics but not necessarily reflect better care, unquote. But the key question, of course, is why would we trust Facebook, Uber, Google, Amazon, and Microsoft with all of our sensitive medical data? They can't even fix basic problems with fake news, security, filter bubbles, bias, nor can they prevent data from 50 million users being abused to run political campaigns. Big tech is essentially about quarterly revenues, and they come to healthcare with a Silicon Valley approach to innovation. Innovate in the gray zone, move fast, break things first, and apologize later. This is not a very helpful approach in healthcare. And this poses one of the most important and hardest problems of the 21st century, in my opinion. Trust, or the lack of trust. We could all benefit if we could only trust others with our data. If we cannot trust or misplace our trust, there will be enormous cost. Let's look at a simple example to understand what trust is. Suppose your plumber arrives at your house to fix your kitchen sink. Do you trust your plumber? If you would have to place a bet on him fixing your sink in an hour or so, would you be prepared to stake $100? If you would have great confidence in him as a professional, his skills, reliable performance, you could take the risk. But now ask yourself, do you trust your plumber with the silver that is in your kitchen drawer? That is seemingly a totally different matter. That is a question that has nothing to do with his abilities, skills, knowledge, and tools. And in order to decide that question and the fate of $10,000 worth of silver, you would need evidence of a different sort. Nothing related to his skills and expertise. You would need evidence of the fact that he is an honest or a morally good person, that he has no intention to deceive you whatsoever. A distinction must thus be made between confidence in the reliable performance of some sort and trust in the moral motivation of other people. Now I repeat, can we trust big tech and their acolytes and subsidiaries with our health data? Can we ever be sure that their services will not be solicited by foreign failing states? Guarantee that they and our data will not merge with companies and databases in the hands of oligarchs who do not feel constrained by the rule of law or principles of ethics? It is against this background we need to situate the discussion about sharing and using identity-relevant data in the health domain. Sweden provides an interesting lesson. It is moving ahead in sharing and pooling of healthcare data. People have no problem, but Sweden is not a company. It is a very high trust society, known for its openness, transparency, democracy for a long time. Now it is getting what could be called its return on trust. Swedish citizens trust their government with their medical data, and in order to emulate this result, we need to understand that trust is a moral phenomenon and that it is tied to the quality of institutions in the context of which ethics is taken serious and is widely known to be taken serious by all. Now, how should we do medical ethics in the age of big data and AI? In a statement on the ruling in the Google DeepMind NHS case, Information and Privacy Commissioner Elizabeth Denham said, "The price, quote, the price of innovation doesn't need to be the erosion of fundamental privacy rights," unquote. And Denham is right. And there are two new ideas here. The first idea is that ethics in the digital world should be about designing things, systems, devices, algorithms, governance systems, protocols, and the combination thereof. If we do not consciously and carefully design for our shared moral values in the age of high technology, then our conceptions of privacy and accountability and democracy and autonomy and safety and security will simply not materialize. Ethics will not be inserted where the rubber hits the road in our day and age. Our talk of privacy and accountability in healthcare will, in a sense, be gratuitous if we cannot provide the specifications for, let's say, the role-based access matrix of a hospital information system. If we do not design for our values, others will fill in the void and design the digital world for their ideas and preferences instead, and often in ways that are not clear to us or are clearly unacceptable. It is true what Churchill said, "First we shape our houses, and then our houses shape us." We become, in a sense, like the things we design. If we want ethics in the 21st century, we must build it. This is what I have referred to as the design turn in applied ethics. And this brings us to our second idea, that of responsible innovation. For if we design for our values in a systematic, transparent, and accountable way, we also may be rewarded with solutions to value conflicts and what seemed in first instance unsurmountable dilemmas. Again, a garden variety example. You want to have a walk outside and you want to stay dry. But unfortunately it's raining. So you face a tragic choice. You don't have your walk and stay inside and be dry, or you go out and have your walk outside but you get wet. The innovative idea of the umbrella would allow you to overcome the conflict and solve your dilemma. The core idea of responsible innovation draws our attention to the fact that we can try to accommodate as many of our moral values as we can at the same time, by design, by tweaking the world, by innovation, by creativity. We could try to be really smart and have both our privacy and security, our health and our efficiency, our economic prosperity and our sustainability. That's what true innovation is. Our research shows that remarkable innovations often achieve this moral sweet spot. That is exactly what strikes us smart about them. We felt morally overloaded by the demand of all these values, the dilemmas that we're facing. But a smart innovation shows us that it does not always need to be a matter of either or, but it could be and. We are looking for new functionality, new technology, new solutions and smart solutions that allow us to have our cake and eat it and help us to prevent having to make those tragic choices. A responsible innovation changes the world in such a way that it allows us to do more of the things that we are morally obligated to do, and that is moral progress. And this applies to medical ethics in the world of big data and AI. We need to accommodate privacy concerns and make use of big data and AI in healthcare. There is no guarantee, unfortunately, that this will always be possible, but because the stakes are high, we have the obligation to explore at least whether there are such solutions. In 1982, the philosopher of science, Stephen Toulmin, published a paper with the title, "How Medicine Saved the Life of Ethics." Toulmin argued that new healthcare technologies and new developments in medicine had caused a renaissance in ethics at the moment that the discipline was about to make itself irrelevant and obsolete. A Dutch colleague recently revisited Toulmin's paper in her inaugural address as Professor of Ethics of Biomedical Innovation at the University of Utrecht under the title, "Can Ethics Save the Life of Biomedicine?" And she argued that now ethics should come to the rescue of biomedicine since it is beset with so many hard moral problems. I have suggested now that medical ethics need to shift gears in the age of big data and AI if it wants to save the lives and dignity of human beings and stay relevant. It needs to engage the digital world in its complexity and its entanglement with industry, and without compromising on ethics, human well-being, human dignity and public interest that are constantly under the pressure of profit maximization. It needs to seek responsible innovations, and it needs to design for moral values. Medical ethics is for a good part digital construction work in the remainder of the 21st century. And if we do ethics along these lines effectively, we may be able to solve our trust problem, which is, as we saw, about genuine and obvious commitment to ethics in a digital age, to be serious about it. Chen and others have nicely captured that idea in a recent New England Journal of Medicine paper in their discussion on AI and big data in medicine, March this year, when they argued that machine learning systems should, quote, be built to reflect the ethical standards that have guided other actors in healthcare, and they should be held to those standards. Medical ethics will have to go digital or become irrelevant. Thank you.